All right, it's 7 o'clock. I think we have a quorum, so we'll get started. I'm Phil. I'm one of the trauma chiefs this year. We'll be talking about Reboa today. So we will start with the case. You get a page, Ryan, 20-year-old male coming from scene, mechanism of injuries in MBC. Those are the vitals that get paged out on the pager. And they're like 3 minutes out. They show up in your trauma bay. What are you going to do? What is your approach to this patient initially? Okay, so Ryan. So you're talking to them, see if they have an airway, bilateral breath sounds, pulses, get a blood pressure, see what their GCS is, all that. So that's their primary survey. So still very tachycardic, still hypotensive, same as in the field. Now what? Okay. Such as? Okay. Okay. Prior to pelvis X-ray, you can maybe check their pelvis and see if it's stable or not. Chest X-ray is negative, fast is negative. On secondary, you note that their pelvis is unstable, and then that is your plain film, which shows. Great. So now what do you want? Okay, what else? There's still blood pressure is 70/40. So start resuscitation, you have a source of their bleeding. You can put a binder on to close the pelvis down. Now what? What are your options?
They're still unstable. See if they respond to that protein in the blood.
Okay.
If they stabilize. Or do you want to finish your second X-ray first?
Let's assume they just have this isolated bad pelvis.
If they improve the blood and they're stable, unstable.
Yeah, so you have a lot of like various pathways that you can go down here. We'll talk about Reboa, but there's a lot that follows from here. What? Yeah, exactly. Doesn't go well.
So sorry, the medicine team is capped.
Yes, it's good for IM hip service. It is a hip injury. So there are a lot of places that you can go, a lot of potential actions that you can, do here. I would be sort of loath to take a patient with 70/40 blood pressure to the CT scanner. So that's probably reserved for more stable patients, and X-fix is described more of historic importance, but closing down the pelvis using that. A binder also works. If their pelvis is closed, I don't think you gain a whole lot from a stable or a stat X-fix. Laparotomy, certainly if there's anything internal, pelvic packing is an option for the persistently unstable patient, either as a bridge to IR or as a sort of definitive therapy. You can leave their pelvis packed and resuscitate. But today we will talk about Reboa. So it's really important when discussing this to talk about patients who this is really a potential option for, and patients who should almost certainly not get this, though in a paper I read yesterday, there are patients who are getting this for some of these injuries who it's been described to generally not get it. But patient selection is everything, and that is definitely supported in the data. So really, this is not a tool for every patient. This is not a tool for every center, every situation, but it is certainly a tool for a very select group. And so those patients are people who have abdominal trauma presenting in hemorrhagic shock, pelvic trauma presenting in hemorrhagic shock. And then outside of the trauma world, this has been described for patients who have ruptured AAAs, OB patients who have uterine rupture, placental accreta, and massive bleeding from that. And then also in the surgical oncology world, prior to any major intra-abdominal resection, sometimes Reboas are placed sort of prophylactically in the event of massive hemorrhage. These are not equivalent to a resuscitative thoracotomy, and it's also very important to understand that point. Why is that, Tess? Why are they not the same thing?
Well, like, we have different indications for them. Like, you'd be worried about like penetrating for your, like.
So what does resuscitative thoracotomy let you do that you can't do with a Reboa. So true. Yeah, so it allows you to address tension pneumo, tamponade, which are two things in the chest that will result in death very quickly. You also get access to any pulmonary injuries. You're 100% right. So putting a Reboa sort of mimics a cross clamp, but does not allow you to do any of those other things. So it's important to understand that. This should not be generally used in patients with neck and chest injuries. There's literature out there now that is sort of going against this. Does anybody know why, Carson? Why would you not use this in those patients? This is true. In real life, it also does increase the pressure and bleeding too. Yes, but that's what's generally the concern is that if you're putting up a balloon, everything above that balloon will now have a physiologic pressure and bleed more, probably before you have control of it. So this sort of segues into the next part, which is relevant aortic anatomy, and then where you are actually going to be putting this balloon when you place it. The aorta is divided into 3 zones for this purpose. Zone 1 is from the left subclavian down to the celiac. Zone 2 encompasses all of the visceral vessels, so celiac, SMA, IMA, and then whichever renal vein is higher. And then zone 3 extends from the lowest renal vein, artery, lowest renal artery to the aortic bifurcation. And sorry, the celiac and SMA. Thank you. The placement is generally going to be in either zone 1 or zone 3. Zone 1 will allow you to control any hemorrhage, really in any part of the abdomen. Zone 3 will be more focused on patients who have a pelvic injury and are having exsanguination from that source. The device that is, I think, most frequently used in ours here is a prime time device, which is going to be right here. There are a couple of considerations that you need to think about when you're inserting this. First, it goes through a 7 French sheath into the common femoral artery. So why do you not put it in the SFA, Ryan? So smaller artery, increased risk of complications, which we'll talk about later. How do you find the common femoral artery? Okay, they're hypotensive. Yeah, so you can use an ultrasound. Your landmark will be, where'd you guess? Where'd you put your probe to look for it? Where? It's a good start. Near? Just distal? Yeah, so about halfway between the symphysis and the ASIS, and then a couple centimeters below that. That's generally where you will find this. But it is very important to put this in the common femoral artery. It is right over the femoral head, which allows you to pull this out and then immediately apply pressure, and that will allow you to compress the your site against something that is solid and not mobile and obtain hemostasis. And that's a huge reason for why you put it there, and also why it's good to use the smaller sheaths. Before, these would be used with much larger sheaths, and you would have to do some type of repair or risk access site complication. And now it's entirely appropriate to pull this and hold pressure. If you do use a larger sheath, that will allow you to monitor a arterial pressure through that sheath distal to where your balloon is up. So you have on the distal or on the tip of the balloon, or on the tip of the Reboa, proximal or above the balloon, you have a arterial transducer where you will monitor the pressure in the aorta. If you use a larger sheath, you can monitor the pressure distally as well, and this becomes valuable if you're doing things like partial Reboa, which is honestly beyond the scope of what we're going to talk about here. For landmarks, if you're putting in zone 1, you generally measure out to the sternal notch, and you can do this just like over the patient as you're down there. So palpate the sternal notch, extend your Reboa device up there and measure how far you think it's going to be able to go. And then similarly for zone 3, you're measuring to the xiphoid process. In general, that's about 46 centimeters and 26 centimeters respectively. When you're inflating the balloon, you will start generally with 8 and 2 cc's in those zones. You increase the volume until the blood pressure that you're transducing responds, and it's very important to avoid overinflation with obvious risks of complications associated with that. And then secure it, because it's very sad when you put this in and it's working and then it moves. It's not a good day. So this is the device. It has a arterial transducer here, balloon port here. This is the peel away sheath. And this is not going to project, but this is posted in at least 10 places in the resident room and then in the trauma bay as well. But again, CFA access, measuring, flushing and making sure the balloon is completely deflated, advancing the peel away sheath over the balloon to protect it as you put it into the body, inserting it. Once it's inserted, once the balloon is past the introduction point, you pull away the peel away sheath and then finish inserting your Reboa device up to the point that you've decided is the appropriate zone 1 or zone 3 placement point. These are coated with radioactive material, and you can also inflate with some radio opaque substance so that you can see it on a plain film. And you really should confirm placement with a plain film to make sure you're in the right spot. And then you inflate, starting with 8 cc's and 2 cc's, and monitor for a change in pressure, which you will generally be able to see. At that point, your job has really just started, and you've started a clock. And so this is not a great, bleeding has stopped, pressure's great, high fives all around. This is all right, now what are we doing? There needs to be a plan. And that's one of the reasons why putting this into pre-hospital areas or into places that don't have the ability to do definitive surgery, definitive whatever, is a problem, because you really, once this is up, that is great. The patient has, a blood pressure to their brain, a blood pressure to their heart, but you are now accruing a ischemic, insult to the rest of the body that's distal to your balloon. So pitfalls with this balloon up too long. It's generally supposed to be up for no longer than 15 to 30 minutes in a zone 1 placement, and then longer up to an hour is described in zone 3. Dr. Sams very much likes to quote that if it's up for long, if you have a cross clamp on for longer than 30 minutes on the aorta, survival starts to approach 0% very rapidly. And so a similar concept with this. If you take down the balloon too quickly, or if you don't tell anesthesia that you're taking it down, those can lead to problems if they've not been appropriately volume resuscitated during your case. Balloons can migrate, so securing it at the skin is critical. And then sheath removal can be a problem. Often if these patients are that hypotensive and get that much blood, they are coagulopathic as well, or have the risk of being coagulopathic. So pulling a large sheath, even if you're going to hold pressure in a patient who's coagulopathic, can be a problem. And so what's described is sort of leaving the sheath for up to 1 or 2 days even, resuscitating the patient, fixing the coagulopathy, making sure that you don't have to actually go and put up another Reboa for anything else, and then pulling the sheath under more controlled conditions. Complications unique to Reboa. So access site, like we sort of talked about, you're putting a hole in the artery. You can have a pseudoaneurysm, hematoma, seroma, and then arterial dissection from that access point. Balloon positioning, so perforation of the either balloon or the aorta is a problem. If you put it up and there's a plaque where you're putting it up, disrupting that plaque and causing embolism from that is a problem. And then ischemia to the extremities, or really just ischemia to the extremity from your access site. If that you're narrowing the caliber of that vessel, if that thrombosis, then you will lose, or that can serve as a nidus for thrombosis, which will cause you to lose flow to the leg distally. And then shared with resuscitative thoracotomy, but certainly worth revisiting again, ischemia to the viscera, and then a reperfusion injury whenever you decide to take the balloon down.
What do you do to prevent that ischemia to the extremities? We've lost extremities to the Reboa. What's one of the keys you got to do when you're putting this in, trying to lower that risk?
Well, I think one thing is
the risk seems to go up significantly if you access the superficial femoral artery. To make sure you guys, we see this all the time in the lab on cadavers. People think that groin crease that you see is where you should be looking, that's the dissecting point, but it's not. Inguinal ligament is where you should be. You should feel that, and you're usually oftentimes above that crease for the common femoral. That common femoral will be about 3 to 5 centimeters in length below that inguinal ligament. You got to access it. Very important.
So we'll talk about outcomes after Reboa placement, and really the caveat to all of this is that there's really no randomized data discussing outcomes and survival for patients who get a Reboa, either compared to patients who don't get any treatment versus patients who get a resuscitated thoracotomy. There's no randomized data. Patient selection is key. So there are 3 patients you are probably considering Reboa placement in. These 3 may look a lot alike, at least initially. Patients with a devastating injury who are going to die no matter what you do, whether or not you put in a Reboa, they're still going to end up dead. Patients who would survive and would do so without Reboa placement, so they're going to do fine. You're maybe overreacting in terms of putting this in. And then patients who would die without the Reboa placement. It's that last group that is very ill-defined in the literature, but it's the group that has this potential benefit, and it's just very difficult to identify that group sort of prospectively to study in a randomized fashion. So there are 2 studies that we'll talk about. These are both on the podcast, so you've heard a little bit about them already, but the first is the nationwide analysis of resuscitative endovascular balloon occlusion of the aorta in civilian trauma. This was a retrospective study, case-controlled analysis using 2 years of TQIP data. They included any adults who got a Reboa within 1 hour, and then compared these to patients who did not get a Reboa in a 1-to-2 fashion. They looked at pre-hospital vital signs, injury-related factors, and then potential complications from this, such as lower extremity. They looked at ED mortality, 24-hour mortality, and in-hospital mortality, and then secondary outcomes were complications related to potential Reboa placement, such as injury to the viscera from that ischemia versus a extremity complication. So in this case-controlled study, their groups were reasonably well matched for this type of study. The resuscitation that each group received also was reasonably equivalent, suggesting that they are a similarly injured group of patients, which is important. Time to either IR or OR was significantly higher in the Reboa group by an order of about 10 minutes for each. So this is not a instantaneous procedure. This does take time to set up, to place properly, and to secure and confirm that you're in the right spot. And then in terms of outcomes, for complications, AKI and amputation of the lower limb were both higher in the group that underwent Reboa placement. And then overall mortality and 24-hour mortality were both higher in the group that underwent Reboa placement by like a factor of 100%. Mortality rates were double. So the conclusions from this study were that Reboa was again associated with those complications, higher rates of mortality. Obvious limitations were it's not controlled, it's a retrospective study, so study design and then data accuracy. They're using a national database. Anyone who's worked with the national database knows that that's a problem. And then a later study that was actually just published in Journal of Trauma tried to do this essentially same analysis using a 4-year cohort of the same database. And they performed a more stringent propensity score matching for patients. And they found that the risk of AKI and limb amputation rates were not different in people who got a Reboa compared to people who did not, but that mortality risk was still there in patients who got a balloon, and that this really would only be explained, they said, by a significant confounding variable that they currently can't identify, which seems, sir, oh boy. No, I'm done. Go for it.
Couldn't you explain it by the Robo increase?
So yeah, yes.
That is the
Yes. 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 Yes.
This isn't really killing people. It must be the life. Well, I mean, anything something that is in it. But, I mean, maybe the most likely expect too, but it's not like
So this one thing about the method, how big was the initial cohort before you did?
Oh, I don't know. I'll get back to you.
My guess is you're looking at like a 5% or less sample.
Yes.
And then because the TICO data is huge, right? I mean, so even like 2 years, even after a 2-year period, when you're looking at 120, I'm assuming that's like 420 out of
400,000.
yeah.
Yeah.
So Like an early days Robo, they were throwing up in everybody.
Well, I do think there's a few things like to point out. One is, they excluded resuscitated thoracotomy patients. So, I mean, really, I would argue that would be, I mean, it's not, to say this isn't an equal comparison, but that's probably another comparison.
Yeah.
For randomized patients to resuscitated thoracotomy. Presumably, people who take care of assumption that they knew how to do a resuscitated thoracotomy. So already,
Yeah, I think there's absolutely some selection bias too there, and people who are putting this up in a non-controlled setting, have the training to do that and feel that this is going to be a benefit versus people who are less, comfortable with it are going to do a thoracotomy, and then that patient will be excluded from that analysis entirely.
right, it makes you wonder, like, it's the same thing, like you said, well, the indications for ER thoracotomy or Reboa are equal, and that's that, but it's like when, Foley came out, we started doing both gallbladders, because, even if it's less morbid than a thoracotomy, if you're more like a unit, and then you delay their care. And then same thing, like, with laughing hernias came out, they did randomized trials, basically, one of the issues that made hernias get better was the learning curve. So if there's only 140 patients, maybe people are studying and they could go.
Yeah. Okay.
That's what you need.
So here's another retrospective trial that uses the AAST aorta database, and this compares people who got a Reboa or a thoracotomy. Again, adults, and these were all zone 1 placements of the Reboa balloon. They excluded penetrating injury, so just the blunt mechanisms, anybody who got a Reboa in the OR, and then incomplete data. The numbers down there don't add up to 285, which I discovered last night when I was reviewing this, but 60% of patients had pre-hospital CPR. 57 of them had pre-aortic occlusion CPR, and then 56 got an aortic occlusion either through Reboa or thoracotomy before they got compressions, or they got no compressions. So in the pre-hospital setting, so this first kind of moving across here, so CPR required pre-hospital. Again, this was the vast majority of the patients included. Survival beyond the ER was not any different between patients who got a Reboa and patients who got a resuscitated thoracotomy, and similarly, survival to discharge was no different between those groups. For patients who had CPR required after admission but prior to either thoracotomy or Reboa, again, there's no difference in either survival beyond the ER or survival to discharge. But for patients who got a aortic occlusion, either thoracotomy or a Reboa device prior to any CPR being initiated, among patients who were hypotensive, there was a survival benefit beyond the ER and a survival benefit to discharge seen in the group that got a Reboa. And then for patients who were normotensive, on arrival, the survival beyond the ER was higher in the group that got a Reboa. So I think this study sort of highlights the importance of patient selection that has to go into the A, studying these patients, then B, figuring out which patients you're actually going to use this technology in.
That study kind of looks like the groups you divided into initially. Like the first comparison is people who were never going to so it's really hard to show this being making a difference in mortality and second group is the one who maybe can help, and the third group is probably
I agree with that. I also thought that their data was interesting because like 50% of patients who are showing up normotensive are dying here, which is an interesting in the ER. So
yeah, but I mean it's probably a group where at least some of those patients.
Yeah, I think this is a group that is most sort of germane to this discussion. But I agree. Yes. You should have been at our rib fractures talk last week.
Oh, yeah.
Equally high data.
Well, there are a couple ways. The comic piece is actually really good at this, where instead of randomizing patients, but that's also hard with something like Reboa, where all the way Reboa, no matter what. time and get up this way. How we done? Is there a resident project?
Hey, Bill, what about military applications? With my office here wearing the uniform, is there any additional utility to Reboa maybe outside of a civilian level 1 or level 2 trauma center in an austere environment or a level 3 hospital?
So we have a JTS CPG on this, which I can go through here. I think there certainly is some utility to this. For anybody who's interviewing here, this is just a not humble brag about our program, but there are a lot of names on this list to include one of our trauma chiefs in terms of who is authoring these CPGs. So we do a lot of this here. Come here. All right. That's really the point of that slide. But this is sort of there are two algorithms for use, and this is really in the field setting. One is for patients who show up with a pulse or not, or who show up with a pulse. The other is for patients who do not. So this is for the do not group. If they have an organized rhythm, yes. Any clinical response to initial ATLS stuff, yes. Then can consider the profound shock Reboa algorithm, which we'll go through next. If no, and blunt trauma, then you can consider a thoracotomy versus a Reboa. If penetrating trauma and CPR has been done for less than 15 minutes, you can consider a thoracotomy versus zone 1 Reboa. So certainly something that is described, and this is applicable to field settings. For patients who show up hypotensive, again, for the neck and chest injuries, less indicated, but for abdominal, pelvic, or junctional injuries, you can consider a zone 1 Reboa. For the junctional injuries, you can also consider a zone 3 Reboa, with the caveat being that you need to be very careful putting these up in a role 1 or role 2, because you still need to be able to provide them with definitive care. So if this is something that is going up and then you don't have the ability to take it down for an hour and you're putting up a zone 1 Reboa, that patient is probably dead. And so just, if you're going to put it up, you need to be very, very careful about that. One of the things that's in the guidelines is to really, you should not be transporting this patient, putting them on a rotary wing with a balloon up. And that's like, if you are doing that, then, or if you're leaving the Reboa in place, someone who is good at Reboa needs to be going with them to monitor that. And if that patient becomes profoundly hypotensive en route, they can consider putting it up then. But the definitive plan should not be Reboa, balloon up, and then transfer to a higher level of care. There needs to be an interceding step. There is a randomized trial going on right now, the UK Reboa trial, which will randomize hopefully enough patients to get Reboa plus standard of care to standard of care alone. Their primary outcome is 90-day mortality. This is enrolling, so we'll see kind of what this shows, but this is the first truly attempt at randomized data for this question.
I think that they don't mandate a physical time as their arm. You know what I mean?
So Dr. Nunez and I were sort of talking before this, but I think the benefit here and what people really big advocates of Reboa will support is like placing it before they get to that point where they will need a thoracotomy, like not waiting, because, you know, their blood pressure is 70 or 60, we'll try to resuscitate. A thoracotomy is certainly not a benign thing. And so I don't think that gets delayed beyond a certain point, but I think you could place a Reboa before you would reach that same decision threshold where you would be doing a thoracotomy. And so it's in that group that is going that way, has a severe injury burden, has the appropriate injury location and mechanism, all of that, who still has a blood pressure. That's the patient who I think would benefit the most.
Some of these patients going to get in place and then not in place
For the study?
Yeah.
I
mean, I don't know.
We'll see how it goes.
Yeah. For the military thing, just you at some point are likely to run into the people you got to be careful about range. I'm talking more special people you'll hear about, like medics placing Reboa in the field. We always got to be aware of the medicine traumatologist, like versus traumatologists, like they want.
It's a shiny crow item, and the special operations world is really interested in doing this pre-hospital. and we've been trying to vigorously shut them down every time they mention that.
But there's a lack of understanding that they just
Step
think we
one.
fix blood pressure and like, boom.
But it's
That's
only
it.
step one.
Right.
And you got, and as he pointed out very nicely, the clock just started, and you don't have much time.
Right.
Like, and just to move somebody, you know, a short distance, even though we got helicopters and all that stuff, I mean, you're gonna burn 15, 30 minutes and that, and you're done.
For sure.
Like,
And then, I mean, these are folks who don't see the tail end when they have brain dead patients and days later they have really good. But at the same time, you know, you can take them rightfully say that there's no data for athlete status, individuals who are very sick and young. But you'll run into these issues at some point.
well, we're in a discussion right now with San Antonio EMS, who's doing pre-hospital core condoms here in town. And our whole discussion is,
I'm about to have a
you
stroke.
know, all you've done is step one. And, you know, university and us have discussed with them, it was not rolled out appropriately. There's been 3 or 4 total patients. I don't think that there is a survivor. One of the problems is that they stay on scene. And so we use the example, we had a patient here who was 9 minutes away driving, who was here about 40 minutes after injury. And we're like, you could have just thrown him in the back of the truck and gotten here, and we have a better shot because you wait before, you know, all that time.
Yeah.
It's the same thing. And you know, because if you're going to do any of this stuff pre-hospital, my opinion is you have to be moving to the trauma center while it's occurring. You staying stationary and not getting the steps that follow